Good morning. Good morning. Welcome to Medical Grand Rounds. Good morning, all. We'll go ahead and get started with announcements. I did want to put out a reminder that next week will be our first annual Portland Clinic Dr. Jeffrey Clevin Grand Rounds Lectureship. We're very excited to be hosting Dr. Trish Critic from University of Washington. She'll be discussing a sepsis update from screening to refractory shock. So please join us next week for sure, and then we'll be taking a 2-week break for the holidays. Today, very delighted to introduce Dr. Will Kennedy. He is Senior Medical Director for Advanced Illness at Care Oregon, as well as House Call Providers. He earned his medical degree from Ohio University and went on to do fellowship in hospice and palliative medicine at Mount Carmel Health System in Ohio. Dr. Kennedy previously worked at Laguna Honda Hospital in San Francisco. For those of you who don't know, this is the country's largest nursing facility for indigent populations. Dr. Kennedy did spend some time here at St. Vincent's early in his career, and then went on to serve also as medical director for hospice and palliative medicine programs at Adventist Health. In his current role, one area that Dr. Kennedy seeks to collaborate on is development of better care for highly vulnerable populations. And in that effort, we're delighted to hear more about their innovative work here today.
So thanks so much for having me. And I was just, we were talking about before is that 10 years ago when I got to Oregon, my first job was here, and literally my son was born almost like a month after we got here at this hospital. So it's this full, and having done Grand Rounds, this is a nice coming home. So, so I have no conflicts to disclose, no financial interests. And there's 3 goals for today in our talk. And that is, how do we serve our community's most vulnerable members living with advanced illness? What partnerships do we need to provide this care? And then how do we develop resilience to moral distress and burnout? So how do we take care of ourselves as we take care of these people who bring a lot of suffering and complexity? So this picture was taken 20 years ago. I was a 4th-year medical student doing a rotation in Boston. I was walking down the street, and for whatever reason that day, I happened to have a camera with black and white film with me. And I was lost in my thoughts, and I looked over and saw this man to my right, and it stopped me in my tracks. And as you can see, his head is in his hands. There's no sign asking for food or for anything, right? It was a moment of just pure despair. And even in the preceding 20 years and all of the different types of clinical experiences I've had, this still stands out as the moment of singular despair that I have ever seen. And I was so moved by this that I took the photo to remember it. And so it's framed. It was up on my wall in my apartment as a resident. It's been up in our office, and now it's up in our palliative care office, which has been there for many years right now as just kind of a reminder and a North Star. And at that time, what I had in my mind was one question. And the question was, how does this story end for somebody like this? And maybe more specifically, how does it not end terribly? Right? You can just look at him and think of the complexities that he would bring in trying to care for him, especially as he was developing more serious illness in life. So I lived with that question, you might say, unanswered for many years. I went through my residency and did a palliative medicine fellowship and did kind of the different types of jobs that hospice and palliative medicine people do, inpatient, outpatient, and so forth. And about 10 years later, I saw this quote by Bill Gates. And this is him talking about his transition from being the full-time CEO of Microsoft to entering full-time philanthropic work. And it's his response to the gross health inequities in the world. And his response was, why isn't anybody doing anything about this? Right? Why aren't governments doing these things that were so obvious could save millions of lives every year? And so you can talk about it, and this is him, the commencement speech at Harvard when he's talking about this to the students and the prospects of their lives. All of us here in this yard at one time or another have seen human tragedies that broke our hearts, and yet we did nothing. Not because we didn't care, but because we didn't know what to do. If we'd known how to help, we would have acted. The barrier to change is not too little caring. It is too much complexity. And even in that moment when I saw that person on the street in Boston, that was as good of a summary as I'd ever seen, right? I would have had no idea how to help him, even though I wanted to help him. So a few years later, I was in Ohio and finished up my fellowship and practicing, and we moved to San Francisco, where I was described in the introduction as taking a job to start a palliative medicine program at Laguna Honda Hospital. At its peak, 1,100 beds, When I was there, 780 beds, open floors. And you can imagine, this is truly the safety net institution of San Francisco. All walks of life, all ethnicities, all types of problems. And I remember I would be working there, and you'd have literally the type of specificity where you'd have a ward where you'd have dementia, people living with dementia and stage dementia, Mandarin speaking, and having the staff being Mandarin speaking. I mean, that was the degree of specialization that this hospital had because of the needs of San Francisco. And these are the open wards. The entire hospital was open wards, basically. This is what it was like when I was there, even though this picture was taken seemingly in the 1950s, maybe, right? And so I arrived in 2008, right in perfect timing, right before the financial crisis. My position was eliminated. 2 months after I got there, I moved from Ohio. My wife loved that. And so they, as a consolation prize, they offered me being the night person doing internal medicine. So I went from thinking I was going to be doing palliative care medicine all day, and instead being up at night, responding to all the things that happen for these patients. But there was a great serendipity to it, and that is they had an amazing hospice on the first floor of the hospital. And so my shift started at 6 or 7 at night, and things wouldn't start get rolling until 11 or 12. The staff was there. And so I would go and sit with the patients, and then there would always be volunteers from the Zen Hospice Project. And so we would just sit down there, and I wasn't really practicing, so it was just the sense of just being with them after being all those years, push, practicing, grinding, and so forth. And because it was San Francisco in the temperate climate, there was an amazing garden that the hospice opened up to. And the hospice, just for context, was open ward as well. So you can imagine having 12 beds and them being, everyone there very sick, and yet everyone's in it together in a sense. But people that could walk would come out into this garden. And so we would come out there, a patient or two that could walk out, one of the volunteers from the Zen Hospice Project. And this is what the scene was. And you can see all these items of remembrance, figurines, obviously the carvings in the trees, the paintings on the walls. And I had worked at an inpatient hospice facility before, which was nothing like this, right? And looking back, I would say it was much more cleaner and not full of life in the way this was, I'd say, landscaped. But I didn't know what to make of it. I mean, it made an impression on anybody that walked out there, but it was clearly something. And these are some of the remembrances that are there on the ground, the stones, right? People that come to Laguna often have nowhere else to go, so they'll live their lives there, right? Deep relationships between the patients and the caregivers and the medical teams. So when I was there, it was such an expansive experience in every way. The nature of the problems, the isolation of the patients beyond the care teams that took care of them, that really became their family, the length that people would live there for decades. And one of the questions I had is, how big is this problem? How many patients are like this? Because this was nothing like I'd ever experienced in my other training situations on the East Coast and in Ohio. And so, just for context, what is the safety net? And this is from the Institute of Medicine. Those providers that organize and deliver a significant level of health care and other related services to the uninsured, Medicaid, and other vulnerable populations, right? It really is the net that catches people as best they can when there's no one else to serve them. But the question that I really had was, I think I understood that from working at Laguna and having somewhat of a sense of being around federally qualified health centers as a resident and so forth. But what I wonder is, how big is this problem, right? If I'm at one hospital and there are 780 people living there in one city. And so I did some more population health research, and this is from the California Health Foundation. So 30% of all Californians are in the safety net, right? And I can tell you what that means. Is that of that 30%, you have 20% on Medicaid, 10% on uninsured. And that's the country as well. California is no exception, right? So 3 out of 10 across the United States have their care received, and the safety net is really the backstop for what they need. So I was practicing here in town at Adventist Health as the hospice and palliative care medical director. In 2010, Care Oregon, the chief medical officer came and said, we'd love to do an outpatient palliative care contract with you and have you take care of our patients exclusively. And this was right after Sarah Palin and death paneling. Care Oregon takes care of vulnerable populations. It sounds great now, but at the time I can remember being in the room, my partner and I were like, are we going to end up on the front page of the Oregonian here for some reason? It was definitely a question about how that would be seen. But we did it, we embarked on it, and I can tell you that if there's one word that experience felt for me was how ineffective I felt in caring for this population, right? Having all of that training and had done years of it and felt very competent and comfortable with the things that would come up with serious illness and end of life. And all of a sudden, I was caring for a population where nothing felt like I was doing a good job, and there was tremendous moral distress. And so what does that look like in terms of what I was experiencing, and I think what other people experience in trying to serve this population when they have a constellation of complex needs and serious illness? So what are some of the things that we see? The patients are younger, right? In Oregon, if you have severe persistent mental illness or you're chronically homeless, you die 30 years on average faster than someone who does not have those problems. So our patients were in their 40s, 50s, and 60s instead of being 80s, right? But they had a geriatric constellation of problems, frailty issues, right? Functional impairment, cognitive impairment, isolation. Mental health issues, 50% of all people with severe persistent mental illness are not being currently treated in the last 12 months, right? Substance abuse disorders, lack of social supports. I could not believe how many people were alone on this journey, right? And because of those other issues, they've often burned their bridges along the way, right? Not on purpose, but those things tend to estrange the loved ones that would care for you. Food insecurity, housing, not surprising, right? Lower health literacy that impairs decision-making, comprehension of what's happening to them. All of those factors are at play. So those are the things that we all see in this room in one way or another when we're trying to care for these patients. But what do the patients experience themselves that we do not see? What's underneath the surface, right? So this is part of a larger list that was compiled by a nun who does palliative care work in Phoenix, Sister Adele O'Sullivan. System barriers and cultural barriers. They don't have insurance, there's complicated eligibility requirements, disorganized services, inaccessible service locations, no documents, no transportation, complex health problems, fragmented silos, right? You have 4 different specialists and you're trying to get across town to get to them. Cultural barriers, provider attitudes, outright discrimination, right? Implicit bias, cultural incompetence, prior bad experience, distrust of the system is a huge one. Language, illiteracy, and disorganized lifestyle. And I can tell you that when I came to Care Oregon, one of my first years, I was sitting at a cubicle with all the case managers, so nurses, social workers, and so forth. And I kept hearing this problem that would come up and them trying to help people, and I could not figure out. I said, I must be misunderstanding this. And here's what it would be. Somebody would have a serious illness, they'd have a lot of these other problems going on, and they had no way to access the services because they had no identification. Right? So if I lost my wallet right now, what would I do? I'd go home, get my birth certificate, call my wife, whatever, somehow go to the DMV and get my driver's license, and I'd be back on my feet by the end of the day. So what if you have no one to support you, you have no driver's license, no birth certificate, and no way to prove who you are, right? And you have a serious illness, and you have all these other risks going on. It was a degree of depersonalization that I had never considered, right? So when Gates talks about complexity and this problem and the way complexity thwarts us from caring for patients, he talks about it in 3 different parts. Is that complexity blocks us to know what the cause of these problems is, how we can create a solution, and how we can assess outcomes. And of course, these are related because if you can't assess outcomes, how can you determine what's working and what's not and work your way through to success, right? That's classic quality improvement, quality assessment strategy. So one of the things that I didn't realize that I learned from the people at Care Oregon when I came there was what is the cause of many of these problems? Of course, there's not one generalization. But if I was going to say what's the one root cause, it's trauma, right? It's the experience of life trauma. This is a growing paradigm. The CDC supports this. This is a growing understanding. It started with the studies of children having experienced traumatic experiences and how this affected their life in all domains as they grew older. But I would also include the experiences of trauma as adults as well, right? All different types. These are populations for whom poverty is its own trauma, being exposed to violence, all manner of trauma, and then growing up and having trauma in various ways, right? So this is a pyramid from the CDC, and it's talking about you have adverse child experiences, right? Exposure to violence, poverty, all manner of badness there, which then creates disrupted neurodevelopment, especially in the areas of executive function, emotional regulation, which then create social, emotional, cognitive impairments, right? The adoption of high-risk behaviors, and I'll call that out right there, is that the degree of smoking in this population is remarkable, and therefore the degree of COPD, lung cancer. Care Oregon, when they build out some of their complex population programs, one of the disciplines they added was a respiratory therapist because it was just endemic in the population. So you have the adoption of high-risk behaviors, and then you have that early onset of chronic illness that we talk about and early death. Right? But it's not just in safety net populations that trauma is an issue. It's a growing awareness that what we do as a healthcare system induces trauma as well, right? So this is the New York Times. 5 million people are in ICUs per year. About 1/3 of them, up to 35%, experience PTSD in the following 2 years after being in the ICU. And that doesn't include the nurses that take care of them or the family members that are exposed as well, right? It's a huge issue. And then finally, this is a book by, a really fantastic book by a psychiatrist named Mark Epstein that talks about the trauma of everyday life, right? And this is really part of being alive. And of course, there are degrees of trauma that one experiences. But one of the things that I noticed when I would take care of very old patients, 100 years plus, was there was always trauma in that person's life. It's a product of living. If you live long enough things happen, right? So he talks about it. Trauma is not just the result of major disasters. It does not happen to only some people. It's an undercurrent of trauma that runs through ordinary day life. And so the question then is, how do we deal with life this way that creates resilience for ourselves, for the people we care about, and certainly for the patients we serve? So in thinking about these things, I'm at Care Oregon. We're doing different types of palliative care models, trying to figure out how do we serve this population best. This is the classic triad of palliative care, right? If you're going to say, what are the 3 pillars that palliative care rests on? This is it. Symptom management, care coordination, identification of goals of care. And if you want to think about it chronologically, is that care coordination happens early in diagnosis, goals of care happens next, and then symptom management, which rises in the last months of life typically, right? But in the population we served, what was the recurring story was that this did not work, right? And what you needed to solve that complexity were trusting relationships, which people didn't have, right? So you have trauma as the cause, as Gate talks about it, isolation and all the associated problems with that. And the solution, in a Maslowian way, as what's foundational, is a longitudinal trusting relationship. And so our palliative care program has been built around getting to know patients on their terms, walking with them, even going to somebody's house 3 or 4 times before you get in the door, right? So this is the work that we've been doing for the last 8 years. And I'll tell you, up until a couple of years ago, it's been a process of faith, right? There's been a moral rightness to it. And I've personally believed that it's worked, but I've never known it, right? I can't say that for sure. I can tell you anecdotes of stories that it's worked in. But does it work for a population? Is it really effective? So 2 years ago, I was looking at some Care Oregon data, and we had looked at what happens to our patients depending on how soon they get into our program before they die or go to hospice, okay? And you could see in these very different categories is the sooner somebody got into our palliative care program, say 12 months before they died, versus if they came in 2 months, you had a radically different outcome in the final months of life. And I looked at it and I said, that's relationship. And everyone on our team said the same thing. But it's our own internal data. Who knows what that means in real life? But then about 6 months later, this study came across my desk from UCSF's Cancer Center. And they looked at the same question and came to the exact same results, and literally their graph was the same that our analysts had created at Care Oregon. So there it is. You can see it. And it's a simple idea, right? Is that the top black dotted line are people that are engaged sooner. And then if they're admitted into palliative care late and that relationship and that trust isn't built, there isn't the time to solidify what goals are, to coordinate and create a plan of care that makes sense for those patients, is that you had a rapid escalation in costs. And the way I would say costs in this sense is really it means misaligned, overly aggressive care for what people really don't want, right? So the second one, and this was just published this summer, was, and again, we were looking at our own experience and trying to build a model that made sense from what our patients seemed to need, but with some uncertainty about how true it was. And that is, as we were doing this work, what we felt was there needed to be a role where someone held that relationship for the patient that didn't have to be necessarily a licensed discipline. Not a nurse, not a social worker, certainly not a physician. And so in the beginning of this year, we hired our first 2 palliative care community health workers into our model, right? And we specially chose them. We knew them personally. They had experience in housing case management, behavioral health, and they walked in running on the door. And so we were watching them do amazing work. And I was talking about this to an audience, and somebody from Kaiser came up to me afterwards and said, do you know about this study? And I didn't. And so this is done at Stanford, randomized control trial. You don't see a lot of randomized control trials in palliative care. But it was a randomized control trial looking at people with stage 3, stage 4 cancer The intervention is aligning them with a palliative care trained community health worker, right? Focusing on goals of care, what they want, and so forth. So what do you think the results are? Almost any intervention works in palliative care, right? But effect size matters a lot, and the cost of the intervention matters a lot, right? Because that means sustainability. So the length of the intervention, in other words, from beginning to end, 6 months on average, increase the documentation goals of care 5-fold, right? Nearly a 2-fold increase in hospice use. But look at this. In the last month of life, 6-fold reduction in going to the hospital and a 95% reduction in costs. Absolutely remarkable results from a non-licensed discipline that holds that relationship with the patient. Right? So this is the classic schematic of what happens and what's maybe you would say is even optimal that happens with somebody when they're diagnosed with a serious illness, right? You have diagnosis up in the top left corner. You're going to get hopefully gold standard curative care, aggressive therapy, hopefully some palliative care in the beginning. What are your goals? Coordinating care, hopefully not a lot of symptom burden then. And then over time, the assumption is that curative care, that aggressive care becomes increasingly less effective and palliative care becomes more of a predominant part of your experience. And then at some point, the curative care stops, palliative care becomes 100% part of the care, and there's a discussion or a decision around quality of life is what's important, not quantity of life. And there's a referral to hospice, right? And then the person passes away, and then there's bereavement services which are required by Medicare for the patient's loved ones who are surviving, right? That's gold standard care for me in the schematics. But I want to show you this graph of Care Oregon palliative care outcomes and see what you think. So these are people that have come into our program, right? And this is what happens after they go into our program. So just for context, the 21% other, there's a lot of surprisingly high percentage of people that move out of the area, things just happen. They lose insurance, something happens where they just kind of leave the model. But of the rest of these, 15% are discharged, goals are met. That's great, right? Whatever they came into the program for, they've needed, they've gotten better, and they're doing something. But look at those two categories. The palliative care deaths, 32%, and the hospice deaths, 32%. What does that mean to anyone?
Patients are scared to go to hospital.
Yeah, so here's how I would say that. Yeah, that's right, is that if you think of that schematic as a schematic, this should be essentially 0 and this should be 64%, right? They should leave palliative care and all go to hospice, but they don't. They stay. Yeah?
Do they have to change teams between
Yeah.
palliative care and hospice?
Mm-hmm. Right. Right. So the difference in these two programs in terms of the benefits you receive or the cost of the programs, however you want to say it, is 5-fold. Right? So what you have is a patient that will say, the trusting relationship, not wanting to go to this space, I will accept 5 times less benefits because this is more important to me. Right? So what does that mean for us when we think about serving vulnerable populations and how we design our models? It means that this is not fair, right? You shouldn't have to make the decisions to go to hospice, to give up your choices, all of those factors, to leave the maybe the only trusting relationships in your life, to receive the best care around your rising symptom burden and other types of services that you need. And then for bereavement, and we'll talk about that, the other piece is, if you're alone, having bereavement services is completely useless to you, right? That's not a good use of resources. It's not meeting your needs in that way. So the point is, from a social justice perspective, from an equity perspective, is that to design these models in a way that makes sense to the population and is most fair to them is that the services have to be provided parallel, not sequential. Right? You don't have to go from one step to the other because that may not be your lived experience and it never will be. Right? So getting back to what I saw in the garden at Laguna Honda Hospital, that I carried with this image with me for many years, not knowing exactly how to contextualize it. And I was up 2 summers ago visiting the Ottawa Mission. And the Ottawa Mission has done palliative care and end-of-life care in the homeless for 20 years. They're probably the place in the world to go, certainly in North America, in terms of what they've learned over that time. And I was having a conversation with their founder, their executive director, and I happened to be talking about the garden at Laguna, just how interesting it was and how to think about that. And she laughed and said, oh, I know the answer to that. I know exactly what that means. And so this is the plaque that they created there, and it's the same idea. So these are the people that have died in their mission, and this was essentially, this is what they needed. They didn't think to do this. The patients that were in there said, I want something to remember myself by on the wall, that you would remember me by. So what it means is people that don't have people that will carry on a legacy, is that memorializing their lives while they're alive with the people caring for them is how you meet that need. And that's what you saw naturally occurring in that garden at Laguna, right? People were saying, I was here, carving their names, the stones, the paintings, and just like this plaque was happening up in Ottawa. So at some point in having these experiences, I saw it, if you haven't seen the Cave of Forgotten Dreams, which is by the documentarian Werner Herzog about some of the oldest cave paintings that have been found in France. And he points out this hand, this person who walked way, way back with a torch into the dark cave and put red dry pigment in his mouth, or her, and put his or her hand up against the wall and say, I was here. Right? This is the deepest human need, to know that we're here. And essentially that's what you're seeing with Laguna, I think, and with the Ottawa mission and the plaque. How do we memorialize lives? How do we honor them in the relationships that we have with them? Because that may be how they see their lives and having meaning. Here's an African proverb saying the same thing. A person is a person because of other people. Right? We are the people oftentimes for these folks. So why does this matter now? Why is this so important? We talked about 30% of all Americans are in the safety net, uninsured or Medicaid. There's a lack of structures. Who is Medicaid taking care of historically before the Affordable Care Act? But moms and kids, healthy people, right? There's no fluency or infrastructure in the Medicaid safety net to take care of really sick folks that require that type of care, right? America's essential hospitals, which is another way of saying America's safety net hospitals, right, operate on average on a 0% margin. The average margin for a non-safety net hospital is 6.5%, right? So they're vulnerable, right? What happens when really sick people go into the hospital? To hospitals, how does that turn out for them financially? Not good, right? And there's very little data to guide advanced illness strategy in this population. Certainly that's what I was learning. I always tell people this story that when I came to Care Oregon 5 years ago, I started calling around the country trying to find somebody that would know something about this. And somehow people got confused, and like a year later, they would call me thinking they'd heard that I knew. I didn't know anything, but somehow that's how confusing. There's just nobody that knows anything about this. So are we at an inflection point, right? Older minority Americans will increase by 160% compared to 59% for non-Hispanic whites. In some urban low-income neighborhoods, the percentage of decedents receiving hospice care, less than 5%. That study was published in the 2000s. Right? And then with the opioid epidemic, a true epidemic, is that are the efforts to curb the epidemic going to affect the access for safety net populations to receive opioids for legitimate reasons? Right? So as I had said in the beginning, is that for many years, this was you might say, a process of faith, right? That the moral distress I experienced originally in caring for these patients, and then building models and seeing success happen, even if anecdotally, was a process of faith. But then as you've seen those research papers, increasingly, I think this is an entirely viable way to care for folks. And this is Paul Farmer, right? The global health expert, famous for doing the work in Haiti around malaria. For me, an area of moral clarity is you're in front of someone who's suffering and you have the tools at your disposal to alleviate that suffering or even eradicate it, and you act. Right? So this is a patient in our program. This is Cynthia. Cynthia was born in Fort Wayne, Indiana, large family, moved to California, has a great love, or had a great love for raising horses. Came up to Oregon 12 years ago. She, I would say, was living a really good life and really has this amazing set of interests, an artist. And she was scheduled to get a screening colonoscopy, just a regular screening colonoscopy, and she lost insurance by no fault of her own a week before. So you can imagine how the story goes from here, right? She doesn't get the screening colonoscopy. Fast forward however many years, and she's diagnosed with metastatic colon cancer. Right? So she ended up in our program, in our palliative care program. She needed housing. She needed food. She was very isolated in many ways. And when I went out to interview her, I spent 90 minutes talking to her, and I had a whole battery of questions. I mean, I'm obviously not an interviewer, how it's going to go. And I think I asked 3 questions in 90 minutes. She just told me the most amazing story of that time. And so much of the story is about how appreciative she is of all the care she has received and the people taking care of her. So she was a master gilder, and her work is in the Heathman Hotel. See that? But I'm just going to give the play here the last 47 seconds of the interview where she's talking about, and you'll listen to what it says, but it's about how she thinks about our opportunities in caring for people.
Is there anything that you would want the physicians and nurses and nurse practitioners and anyone else that's taking care of you, is there anything you'd want them to know and what you've experienced or what you see now?
Just how important it is to us. And I'm sure some of us as patients aren't able to show our appreciation or to verbalize it. And so I'll speak for them. It really means a lot to us. Don't stop.
Here it is written out. So really she's speaking for all the patients that aren't able to tell us how much it means that we care for them for whatever reason, right? And not to give up. Don't stop. So in thinking about caring for these complex patients, and as I said, think about all the things that Cynthia needed and how hard it would be to provide that if you didn't have a model that was designed for it, right? Housing, food, social support, all manner of supports that she needs. And she still has a lot going on, right? This is an ongoing process. And how much she talks about, the nurse was there with me, her nurse, and she's just saying how much the nurse is just her connection, how much love she has for her nurse in the interview. So when we think about those things, we talk about the challenges in caring for these patients and how it's challenged to practice medicine, to do healthcare, whatever your discipline it is today, right? And it's even more challenging to care for complex patients because, of course, to open the door and ask patients questions around these things puts you in a very difficult situation because how are you going to solve these problems, right? And so this is the 2018 Medscape survey, 15,000 plus physicians. And by the way, there are similar data for different healthcare disciplines. That's just the physician one I put up here. But these are the burnout rates that physicians reported. 42% overall, internal medicine 46%, family medicine 47%. And the last time I gave this talk, somebody said, well, you know, it's a survey and it's self-reported and so forth. But the truth is in this data, you can correlate it. And when people point high on burnout, you can predict what's going to happen in the next 12 months for them. Leaving their jobs, cutting back on hours, all kinds of things that we wouldn't want to have happen and they wouldn't want to have happen. So Arif Kamal, the palliative care researcher at Duke, asked the same question to palliative medicine folks, palliative medicine physicians. I remember filling this survey out however many years ago. What do you think their burnout rate is for palliative docs?
Less.
Okay, so less. I'm going to price is right it if you don't go too high. So 62%. Right? Very, very high burnout rate. Right? So these are huge issues. And the point that I would say is that if you already are struggling because this practice is not working right, the modern healthcare is transactional. You spend so much time staring at EHRs. There's all these challenges. To think about caring for the most complex patients who need it the most is very daunting, right? And there's no easy answer to that. There's no silver bullet. But I think one of the solutions is how do we build partnerships and how do we create a community of supports so that these patients get what we want, what they need, but also so we can take back what gives us meaning in medicine as well, right? If you think about the patients, and I can tell you this personally, the patients that I've had in my life where I felt the most moral distress around and I found the most satisfying, complexity is in both of them, right? The difference is whether I could do something about it or not, right? So going back to Laguna Honda Hospital, Victoria Sweet is a longtime physician there and also truly ambitious because while she was practicing, she went back and got a PhD in history. And So she wrote a book about her experience in working there, God's Hotel. You can see Oliver Sacks calls it required reading. And it really captures the history and really why Laguna Honda is so important about what it tells us about what's possible with medicine. And she has a quote in there. In the Middle Ages, charity was accepted as doing as much for the giver as much as for the receiver, right? In caring for these patients, I can tell you, almost no one leaves our palliative care program, our disciplines, right? They find it so meaningful and life-giving, right? In doing that is that there's a kinship and a mutuality in this work if it can be set up right to care for these patients. And so this is what she's talking. Another way of saying it, Mother Teresa says, our big problem is we forget that we belong to each other.
So how do you become part of the 38%? What's the difference between you and the 62%?
So the question is, how am I not burned out? And I would say,
I don't mean you, but I mean
well,
your organization.
can we put that in the parking lot to the end of the talk? Yeah, it's a great question though. Yeah. So, but here's get to that point, all right? And so there's no silver bullet. There's structural issues and why people struggle in finding meaning and not being burned out in their care. But there's also interpersonal issues something can be done about. And this is Tony Bach, who's up at the University of Washington, spent a lot of time thinking about these issues. And he provides 2 pieces of advice that are relevant today. 1, don't stop. Don't keep doing the same thing that's not working. Find ways to iterate, prototype, create new ways of caring for patients, new ways of practicing that make a difference for you. Right? That type of idea of possibility, of iteration, in his own way is resilience building, I think. And the second one is build bridges. We need a multi-stakeholder approach, right? And of course, that is highlighted and so important in complex populations. Even if you have the most integrated medical team, if you don't know how to access the housing world or the behavioral health world or all those things, you're still stuck, right? I was amazed when I came to Care Oregon how little I knew about anything besides my little medical box. I couldn't believe it. I felt like, how could I have been practicing here for all these years and had absolutely no awareness of all these resources that are right around us? So I want to give you a story about someone who has walked this path. Does anyone know? Anyone know her? It's an old picture, so you might know her but not know this picture. Nobody? So, yeah. So this is a 1990s version of Benneth Husted, who founded House Call Providers. But in the beginning, here's the important part. She considered it her mission life to serve vulnerable populations. She grew up doing home visits with her dad, who was a family doctor, and realized there were a community of vulnerable patients here in Portland who needed these services. So she started a practice on her kitchen table, right? Worked for 3 years, essentially making no money on her own, and did this for the next 25 years, building a practice. One person, one vision, one mission. Here's another early photo of the original team. I've actually met a couple of the original board members, which were nuns on the practice. I mean, it was quite amazing how incredibly small this effort was in the beginning. And of course, when you hear this story, for me at least, it's always the Margaret Mead quote that we always hear, right? Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. Benneth embodies that story. It's just amazing. And what does it mean today? She started in the early 1990s, one person at her kitchen table, right? So this is the practice that I work in, right? 25 primary care providers, hospice, palliative care, almost 2,000 patients being served in our community from one person. Right? This is an infographic that was done in 2015. So that's 2015. So that's 135,000 house calls that she was the beginning of for really vulnerable folks. Right? Another part is that it's hard to be a prophet in your own land. And one of the things I've realized is House Call Providers is nationally known for their work. They were the highest performing site on the Independence at Home study, which was a CMS demonstration project. One of the highest performing CMS demonstration projects that's been done. I didn't know any of that, even though I partnered with them taking care of patients. So last year they partnered with Care Oregon. Now it's all one organization. It merged. And it's the same idea to help leverage this model and bring it to more patients. Care Oregon became financially involved with them because they wanted to ensure that the practice could expand and remain viable in our community as a community asset for vulnerable populations. So the second piece is, the second thing that's happening in our community that I want to talk about in vulnerable populations is the Blackburn building. So this is going to open in the middle of next year on 122nd and Burnside. And it's 6 floors. Poverty's migrating east in Portland. The first 2 floors will be a full-scale central city concern type federally qualified health center. So what does that mean? It means you're going to have substance abuse services, mental health services, robust primary care services, all the things that one might need. On the top floors, you're going to have supportive housing for people that are coming out of different types of substance use treatment, et cetera, where they need housing for a while, they've been homeless. But on that 3rd floor will be the country's first built from the ground up inpatient unit for palliative care for the homeless. 10 beds, right? I can tell you from going up to Ottawa, which is why I was there to understand this, they will be filled. Ottawa started with 8 beds, went up to 12, 14, now they're at 21 beds. Ottawa's about the same size as Portland, right? People die on the street here, all kinds of things happen. But what is the importance? All of the community hospitals, including Providence, supported this build, right? No one entity could create this. Just like house call providers requires it to be a community effort. And so to serve populations that need us the most, you have to partner together. That's one of the great lessons, right? And it helps support ourselves because when you start partnering, you become stronger yourself, right? Solutions become possible that weren't there before, and what becomes morally distressing becomes part of the meaning that you have in practice. So this is a proverb, another African proverb. If you want to go fast, go alone. If you want to go far, go together. And so why does that matter? Why am I here? Is that for the years I was practicing, it was about trying to figure out, can we do this work? And then very quickly, not because of my doing, but opportunities have arisen with house call providers as a community asset, doing home-based primary care, palliative care, and hospice for vulnerable populations, and then having the country's first from the ground up inpatient palliative care unit, is that those are opportunities that will only thrive if we think of them as community assets. That's how it survived in Ottawa. That's how it's thrived in Ottawa, is that Ottawa sees that work as part of their mission as a community, that no one dies on the street there, that vulnerable populations, whether you're homebound or have other needs, that your needs are met, right? And it's also about what kind of community do we want to live in, right? So Gates ends up that idea around complexity and caring and talks about why this is so important. But humanity's greatest advances are not in discoveries, but in how those discoveries are applied to reduce inequity. Whether through democracy, strong public education, quality healthcare, or broad economic opportunity, reducing inequity is the highest human achievement. So that's the goal, and thank you for your time. Yeah.
Hi, Claudia, that was fabulous. Do you think there will be opportunities for residents to rotate this inpatient health?
Yeah, so we're working on, so the question is, will there be residents to rotate at the Blackburn building, which is the inpatient palliative care unit? And I can tell you that we're actively working on, even I'm actually working on this, is that how do we create training opportunities for residents and other disciplines, right, not just physicians, to go through both house call providers, which is already happening, and then the Blackburn building. Because if you're not exposed to these models and these populations and these different types of practice, you're not going to end up being able to, even imagining being able to do this work, right? And I think that the training model that really exposes a potential provider to a population that already has occurred for many years here is Central City Concern. That there's a lot of OHUC residents that rotate through there, which then is really a fantastic thing.
Our residents have been going to Southwest Community Health Center, which as you know is shutting down.
Yep.
And I can see some heads nodding that they would probably love to have some more opportunities.
Yeah, I think if I could, my dream in 10 years is that this is just absolutely tremendous flow through these things because you just have to see it, right? See what's possible. Yeah. Go ahead.
I'm interested in the experience of the doctors that are working with the community health workers that have the close relationship. Because I think I feel like I'm supposed to have the close relationship with these complex patients be what is filling that cup, but sometimes it is what is burning me out. And so I'm sort of wondering, what is then the primary care doctor's role or the palliative care doctor's role, and how does that sort out?
I don't know if there's one answer to that. I mean, I think part of it is, and this is just my personal bias, is that there's a sobriety around what one can do and what one's team member does, and that there's a satisfaction that's gained from that as what our team does, right? Is that you as the provider cannot do it all, right? And that there's a lot of things that happen in our teams where our community health worker holds that relationship and really drives things, I would say, in positive ways. And I'm involved, but it's not something that I'm necessarily, I'm deriving that satisfaction almost vicariously through them. And oftentimes I would say, I think that really spans to the other challenges in palliative care, like having advanced care planning conversations and developing goals. I mean, in today's healthcare, it's just not designed where a physician is going to be able to do all these things, in my opinion. Right? This is a team-based effort. We're sitting down with somebody for an hour to have this conversation. If you're a busy primary care provider, it's tough. Right? Does that answer your question? Okay. Yeah. Hi, Woody.
I'd like to sort of circle back to one aspect of Don Sutherland's question that's in the parking lot.
Uh-huh.
And this has to do with opening up another area of complexity on this, and that is, how do you pay for this? You know, for physicians involved in this, we only see a small piece of
Right.
Financial complexity of this. And it may be well beyond, it's worth it a grand rounds on its own, but could you sort of, I mean, let's open up the door on that and talk a little bit about the financial complexity.
Right, so the question is, how do we pay for these efforts that are really more expansive than a medical intervention, that are multifactorial, right? Whether it's social determinant supports, behavioral health supports, community health workers, medical interventions. And I think there's a couple of answers. One of them is that in Ottawa, it's a community responsibility. It's a community effort. So in other words, for example, those Blackburn beds are going to be very expensive. There's no doubt about it, right? So in Ottawa, they have charity, they have the provincial government funding it. There are many stakeholders that actually benefit or lose in these equations for which they do not realize. So we're in the beginning of starting a Oregon Serious Illness Coalition, which is a model that Atul Gawande has championed in Massachusetts, to bring together the stakeholders who have an interest in this work and then would be long-term supporters of it. So in Ottawa, what they've done is that they have all those different stakeholders, and then the provincial government has done outcome studies showing, oh my gosh, we save so much money and this is such a good thing, rather than people, having all these bad outcomes. So I think that's one piece. I think the second piece, which is more around house call providers, is that even house call providers, which isn't doing those different areas like housing or behavioral health, but it's a nascent model, right? In other words, it's at the cutting edge of doing home-based care. That's not the way healthcare has typically been supported in the United States. Is we have to think about how we can pay for those models as well, just through more increased payments. Like health plans need to pay more for those services because it benefits. Yeah. So, does that help, Woody? I don't know if that answers the question, but yeah, I mean, it's right. That's one of the big. It's its own lecture, right? Yeah.
Do you have any medical laboratory capability?
So in house call providers, like the home visiting model.
You need some kind of laboratory test on somebody.
Mm-hmm. So they'll draw blood, but typically they partner with agencies around skilled nursing and infusion. Those are partnerships. There are home-based practices that do it all, though. Mm-hmm. Yeah, that's just the way this practice has come about. Yeah.
It seems to me, thinking about Doctors Without Borders as a population, that this is also a population that needs care that they're not getting. And I wonder what the opportunities are thinking along those lines. As you know, Doctors Without Borders is extremely successful in fundraising as well as delivering the care. Yeah. And I wonder, for those of few old guys who can't participate except maybe giving money, how do we do that?
Yeah, so the question is, how do we support this if we're not going to be actively involved in some ways? And I think that's part of the work that we have to figure out together as a community. And I do think there are ways that it's being done. I mean, it would be another lecture, but there are models that where people can contribute. And I think part of that challenge is saying is, if you're going to contribute this money, what are you supporting? So for example, could you be contributing to leasing one of those beds for a year at the Blackburn building? So in other words, my contribution is paying for somebody who would otherwise would be dying on the street potentially, but has housing. I mean, how do you make that connection?
Because I'm sure you've been told you're an extremely effective fundraiser, among the other things that you are.
I wish that was more true, but yeah. Yeah.
So on the theme of the finances, your idea about palliative care and hospice running in parallel, my experience with some of my patients is that a hospice is just like an overwhelming burden still to them, whereas palliative care is not. So can we keep them in palliative care and get some of the resources?
Yeah, so I think that the short answer, I think there's two ways to answer that. So the question is that an artificial distinction between palliative care and hospice? I think so. But is that the two answers are,
Big financial.
right. So much of medicine is what's defined what's called path dependence, right? It's the flow of money. Things have been built sequentially on where there's support. But it's not true to patient experience like you're saying, right? I mean, in Canada, when I was up there, they're like, well, hospice, palliative care, what does they mean? Like it doesn't make any sense. So, but it's defined by benefit streams here, right? But I think that's going to change because it's coming for sure, which is that Medicare Advantage plans are going to be responsible for their hospice benefits. And all of a sudden, essentially overnight, the health plans are going to be like, whoa, right? Because right now, if somebody goes to hospice and they're on the health plan, they revert to Medicare fee-for-service. That's not necessarily an alignment of incentives. And so I think what you're going to see is when that happens, you're going to see a lot more of kind of a more patient-focused alignment of those resources.
I wanted to circle back to one of the slides that you had when you were talking about trauma.
Uh-huh.
A coworker and I give a trauma-informed care talk to our community, and one of the things that we really like to sort of call out in that pyramid is the slice that talks about adopting high-risk behaviors. And just the and the second part to that sentence is those are often, and you know this, but I'm just saying this out loud, that those are often behaviors that are adopted as ways to minimize the stress and strain that comes. And I think that's worth calling out because I feel like that slice is actually where the wheels come off when we talk about empathy. And we get really judgy around adopting high-risk behaviors. But those are behaviors that are adopted because people are looking for any way to soothe what's traumatic for them. And in some cases, to feel something. If the trauma has been neglect, then actually it can be to feel something.
Right. Thank you. That's beautiful. Yeah, and what that makes me think of is the way Father Greg Boyle, the Jesuit priest who works with the former gang members in Los Angeles, he would say is that all behavior is a language.
Yeah.
Right. What is it telling us? Right. So thank you. Yeah.
So, I guess I can say it in this crowd. We do palliative care in the community, and many of the patients that we see can no longer getting into a physician or provider's office is merely, it's next to impossible. The family, looks at us and goes, "Are you kidding me?" So we do refer to you quite a bit to provide providers who can come to the homes. What is your game plan for increasing the amount of your providers so we can get better coverage?
So I'll reframe that in a slightly different way. Historically, and I've had some version of this conversation many, many times, is that historically there's been much more demand for the primary care and house call providers than there's been supply. That's the simple thing. About a year ago, we brought it down to the lowest it's ever been. And so now it's zip code based, which is a weird way to think about things, but it's like if you refer a patient from one zip code, you might be in next week, and somebody else, it might be a month or two. One of the ways that's been framed to me, and I think it's a work in progress, I'm not sure there's an easy answer to that, but one of the things that somebody said to me is, if you call up a PCP and you're like, I'm going to come in as a new appointment, they're not like, come on over today, right? That's going to be a month or two out sometimes if it's a busy practice. And so I think there's a framing issue as well, is that, because unfortunately when you call that person that needs a PCP, it's often like, we need them right now. And it's just, so oftentimes what we do now is that we will actually send out some of our palliative care folks to bridge them until we can get them on primary care.
And that's what we tell them. It's going to be a while,
Yeah.
but in the meantime, fill out the forms, talk to them.
Yeah. I think it's a framing issue in some ways, like expectations matter. Yeah.
Sure, we
Yeah.
try to not set them up to think
Right.
somebody will be there tomorrow, but knowing, because we try to do that value planning down the road when you're not going to be able to leave the house, this may be the service that you need, so therefore, let's get you in the queue as early as possible.
Right. Yeah. Yep.
The opioid epidemic is a very heavy burden for all sectors of the profession and the community. what do you view as your game plan to deal with this? Because I suspect more and more will be coming your way. How are you going to handle that?
So the question is how to handle the opioid epidemic in the context of what I just described. And it's a big concern for many people in palliative care at the national level. I mean, I see a lot of conversations around that. And the best answer I can give you is, and it's not a population health level answer, is I think there is a great opportunity to learn and adopt safe opioid prescribing practices that ensure that pathway, right? Are you checking the PDMP, right, the prescription monitoring drug program? Are you having there's all kinds of strategies around this that are done by different programs that I think work really well. And so are you doing that, which then creates essentially a comfort with prescribing in these populations, right? But I think the other part of it is, and this is the other fair part of this, is that if someone has what they call pain, it may not be pain that opioid is the best treatment for, right? The pain of life, right? The pain of chronic illness, all of those things. And if any of us have done palliative care, the classic example is someone's on an IV drip of pain medicine, they're somnolent, and you wake them up and say, what's your pain level? 10 out of 10, right? You know, and it sounds comical, but there's a truth in that. That is their experience of life. It's just that saturating their opioid receptors is not going to be able to treat that pain. It takes something else. So I think there's a more nuanced understanding of not being so binary around opioids, non-opioids. So, yeah.
Think back to your picture of the gentleman sitting on the box.
Uh-huh.
Despair,
Yeah.
and then your slide on relationships as being the key. And I think there are many, many people, both professional, medical professionals and non-medical professionals, that have the same feeling that you do when they see somebody like that. And the overwhelming thing, as you pointed out, is they don't know how to do anything.
Right.
But there are also tremendous untapped resource. Do you have ways of trying to tap volunteerism to provide some of the relationship and to increase your contact with people that you need to do that can merge then with more professional part of your organization?
So the question is, are there ways to build on that idea that relationship is intervention, right, in a non-medical capacity? And so I think the answer is yes. There are some wonderful models out there, like the Zen Hospice Project, who's done volunteer training for 30 plus years in this sense, and as I experienced them in Laguna Honda Hospital. And so right now we are in the beginning stages of that, of building a volunteer program for our palliative care program in that sense. But it's a different population and different needs, and so it's kind of figuring it out as we go. But yes. And I think people want to do that work, right? I think that's, yeah. Yeah, I in my perfect world, we'll be partnering with the Zen Hospice Project to develop a volunteer model for folks that want to work in these populations, what that looks like.
No, we're just about at 9 o'clock. Thanks for your engagement, and feel free to come on down. Thank you, Dr. Kennedy.
Thanks a lot. Thank you very much.